the shortest journal article I've ever done a journal club presentation on. All right, so our article for discussion today is no evidence of compensatory drug use risk behavior among heroin users after receiving take-home naloxone. So there is no spoiler because the title kind of gives away the whole message. These are our CE objectives for this afternoon. And here's just the template that we're going to walk through. I know some of the other folks have used different formats. I like to do this because I like the colors and it helps to keep me organized. So this is our citation in case that you're looking for the article. It's the one that Kay was able to send out. And I know it's just a couple pages. That's why I felt compelled to give that disclosure, because that may be the first thing some of the students look at is how many pages. So a little bit of background. There's been, with the opioid epidemic, there's been increased interest in enhancing access to naloxone to help with addressing a number of the overdoses that are occurring. I'm almost knocking over my drink. In Ohio, Project Dawn's one of our larger ones. So really trying to increase education and supplies of naloxone to get it out into the community, into the hands of folks who could use it to save lives. So it doesn't sound like it should be a negative thing or something that should raise concern, but concerns have been raised about the potential for this type of initiative resulting in compensatory increases in opioid use. So the thought being, if we allow there to be more naloxone out and available, individuals are just going to use whatever they want because there's naloxone there that somebody could revive them. So a little bit of pushback to allowing that increased access. And it had been documented that that's happened with a couple of other initiatives like needle exchange programs and things like that. So not unique to naloxone, but definitely a consideration. So the article that they cited in the article that we read today, I did pull just because I was curious. They said that they had done a survey. So this was based in San Francisco, California, and they did a survey of 81 individuals who were using drugs intravenously. And when they did the survey, so it was a structured survey that was had both kind of closed answer and open-ended, close-ended and open-ended questions. That's what happens when you get me on both ends of the Friday. I get tongue-tied. So of those 81 patients, they found that 89% had witnessed an overdose at some point in their life. Of the 89%, 90% of those patients did attempt to assist. So they were trying to do something to assist the patient that they encountered who had overdosed. But despite the fact that 90% of them were trying to help, only 51% activated emergency services. So they were not going to call 911. This was a little bit earlier. I believe it was 1999 to 2000. So maybe some of the cell phones weren't quite as ubiquitous as they are now, but that did strike me. 87% of those individuals were in favor of getting some type of overdose management training. So they saw it happen, they wanted to help, they were interested in being part of that program. But here comes kind of where some of the justification for the concern comes in. Of these individuals, they reported that after they've taken the training, about a third of them would feel more comfortable using more heroin. So they'd be comfortable using a greater amount if they knew that there was an overdose remedy readily available for them. 62% reported that they are not likely to call 911. So that's up even higher than the 51% who said they didn't when they encountered someone. Because they had the naloxone, they may be a little less likely to activate emergency services. A third of them reported that they would leave a patient. So if they find a friend who had overdosed after they administered the naloxone, a third of them would feel comfortable leaving the patient alone. And 46% of those individuals reported they didn't think that they could stop someone from using after they had been revived with naloxone. So if they find somebody who had overdosed, they use naloxone, that person wakes up, they're in withdrawal, not feeling so wonderful. 46% of people said, I probably couldn't stop them from using to try to get rid of those withdrawal symptoms. So this has been cited as some of the justification for where those concerns come in. So that's the question our study is trying to address. So whether participation in a naloxone overdose training alters the pattern and frequency of heroin and non-opioid drug use in two populations. So in patients with opioid use disorder, both those that were actively in treatment as well as those that were not actively in treatment. So they're looking at, if we give naloxone and have education, does this change how much patients with opioid use disorder are using? So how did they go about this? This was a component of a bigger trial, and I did try to figure out where the bigger trial was. I was unsuccessful. So I just kind of went with as much extra information as they gave us here. So the bigger trial was looking at education and naloxone distribution. This was a secondary analysis, so it wasn't necessarily powered in any way specifically to see the difference here, which is a bit of a limitation. And even though the participants were followed for a year in that bigger trial, the results in this particular study were only baseline, 1 month, and 3 months out. So we really didn't get that longitudinal picture. So what did they do? They recruited patients. I'm assuming they were adults in the New York City metropolitan area. So they used print and online advertisements. They were looking both for individuals who were, we'll see the diagnosis of opioid use disorder in just a second, but who were actively using, as well as those that were engaged in treatment. And they did provide some compensation for them. So $25 if they completed the initial screening, and then $50 at each subsequent follow-up visit. We know that there were probably at least 3, so 1 month, 3 month, and then that 12-month for the bigger study, but it's not clear if there were more in between. Because it was New York, I pulled a subway picture, the D train. I picked that one because it goes to Yankee Stadium. And hopefully someday we'll be able to get back there. So what did the patients have to do? Once they were recruited, what did they need to do? So there was an initial telephone interview to see if they met criteria. And then they came in person to the New York State Psychiatric Institute. And they did an in-person evaluation. So there was a clinical interview that was done where they collected information. They used the Addiction Severity Index. So the Addiction Severity Index evaluates 7 different areas. So medical, employment and support status, alcohol, drug use, legal issues, family and social supports, as well as psychiatric issues. And then they also collected some self-reported information from the patients. This is where we're going to get some of the multi-substance use as well as the quantity information. We know, at least in terms of this, that they met them at baseline with that screening to get some initial information, then at 1 month and at 3 months. They were able to maintain contact. So they had a contact form that the participants had to fill out that included contact information for themselves, close family members, and friends, so that maybe they weren't able to get in touch with just the participant themselves, but they did have releases to try to get in touch with some people who might be able to track them down. So the specific enrollment criteria, so the patients had to meet the DSM-4 criteria for opioid dependence within the last 6 months. And they needed to have enough capacity to provide consent. So interesting, they did not have to be in treatment, and that's why they were looking at those 2 populations. They excluded patients that had active psychiatric disorders. These were the 3 that they called out specifically, and they excluded patients who had previously had training on opioid overdose prevention. So if they already had the training, it would have messed up some of their baseline data, which makes sense. So their outcome measures, they were looking at 3 different things. So the addiction severity index, they were looking at the quantity, specifically of heroin use, because they did have individuals who were heroin users. And this was likely at a time that might be just prior to fentanyl becoming the most prevalent. And then the frequency of polysubstance abuse. So looking at the other substances that individuals were using. They analyzed this data by using a repeated measures ANOVA. So appropriate because they were comparing baseline to the 1 month and the 3 month in the same individuals. So what did they find? This is some of the demographic information. So I split it for the patients that were not in treatment and those that were in treatment. I know they called them active heroin users, but I couldn't bring myself to use that terminology. So we're just doing not in treatment and in treatment. Their demographics were interesting. So the majority of the patients that they recruited were of Hispanic or Latino descent, then African Americans, and then Caucasians. The vast majority were male. For those that were not in treatment, the average duration of their use of opioids was about 17 years, but there was a standard deviation of 10. So really anywhere from about 6 or 7 years to 26, 27 years. For those that were in treatment, again, similar demographics. And they were able to retain, at least for the 3 months, a significant number of patients. That money may have had something to do with it. So they had 92%. There were 61 patients in the participants that weren't in treatment group and 69 patients that were currently actively in opioid maintenance therapy. They were able to get 92% of them to return at 1 month and just under 90% to return for the 3-month visit, which I thought was impressive. This was the figure that was taken directly from the article itself. So there's the three different outcome areas that we talked about. So heroin use, they measured it in bags per day, and that was self-report by the patients. So there were significantly lower amounts of heroin that was used in patients who were actively in treatment. So if they were getting methadone or buprenorphine, they weren't using nearly as much heroin as their colleagues, which is encouraging. For the individuals who were not engaged in treatment, the amount of heroin that they used from baseline before they got the training to 1 month after training, 3 months after training, actually did decrease. So it decreased from maybe 5.6 to about 4.5. So clinically, is that significant? Maybe not, but it did look like that was moving in the right direction. It would have been nice to see that 12-month data and see if that continued to trend down. I'm going to pause on the poly drug use because we'll talk about that in detail in just a minute. And then looking at the addiction severity index. So again, the individuals who were actively in treatment had lower scores than those that were not engaged in treatment over the entire time frame. But for those that were not in treatment after they got the training, they actually saw a decrease in their addiction severity index, which the authors were suggesting meant that they're using less and maybe they're experiencing fewer outcomes because they are using less opioids over time. Just from a limitation standpoint, it would have really been nice to see some additional factors if they had done some maybe looking at other pieces of what's going on in the patient's life, employment status, if they're enrolled in school, any type of drug testing data to be able to provide an additional perspective on these results. So as I mentioned, they did see statistically significant decreases for the patients that were not in opioid treatment after they had the training on naloxone, which is interesting because they had expected it was going to go in the other direction. For the patients that were involved in treatment currently, after they got the training, they didn't see a difference. So they didn't see a difference in the amount of heroin that was used, if they used other substances, or in their addiction severity index. So it didn't improve, but the good news is it didn't get worse either. So related to those other substances, the most common ones that they saw in this patient population were benzodiazepines, cocaine, and marijuana. So this looks a little busy now that I have it on my little screen here. So there's two different groups here. So the patients that were had opioid use disorder that were not in treatment, that's our first group, the no TX, so no treatment group, and then the participants that were engaged in treatment, the TX group. Then for each of the bars, so for the first 3 bars, so that's the marijuana at baseline, the marijuana at 1 month, the marijuana at 3 months. So in the no treatment group, we see a pretty significant decrease in the amount of marijuana that those patients are using over time. They did not see a difference for cocaine. That's those middle 3 bars, the purple, the light blue, and the orange. And they did not see a they did not see a difference for the benzodiazepines. So numerically, it looks a little bit like there's a decrease, but those were about the same. So we saw some improvement with the marijuana numbers. For the treatment group, again, the first 3 bars are marijuana, baseline 1 month, 3 months. The next 3 bars are cocaine, baseline 1 month, 3 months. Last 3 are benzos, baseline 1 month, 3 months. And again, they didn't see a difference. So kind of take home for the patients that were in treatment is just because they got the naloxone training and had access to naloxone, it really didn't change their use of any other substances either. For those that weren't in treatment, we did see a bit of a decrease in marijuana and maybe a decrease in the benzodiazepines. So what does this mean? Essentially, there was not an increase in that compensatory risk behavior. So just because they were educated on overdose and they had naloxone that was available, we did not see an increase in risky behaviors or an increase in the amount of opioids that were being used. For the record, so they did use the addiction severity that was a little bit more objective, but it was self-report on the amount, the quantity of the other substances as well as the heroin that they were using. And that's why I had mentioned having some of that testing data, maybe it be urine testing, maybe it be serum concentrations, that'd be helpful just to ensure that, yep, that's exactly where the trend was going. So clinically, does this make a difference? I would argue yes. So there does not appear to be an increased risk of compensatory behavior in patients who are provided with naloxone. The study said it was 42 states. I believe we're up to 47 states now that have increased access. So by having these educational programs, by allowing naloxone to be out there, it does increase the chances that somebody could save someone's life if they come across them in an overdose situation. And hopefully this will help decrease some of the opposition to providing these educational programs and access to naloxone, because we're not quite out of the woods yet related to the opioid epidemic. So that is it, and I will turn it back over.
And thank you